Good afternoon and welcome to today's webinar with the ILPQC addressing birth equity and improving outcomes together. Our wonderful panelist, Dr. Ann Borders, who is an MD, MSc, MPH in maternal fetal medicine. She's at North Shore and also the executive director of the Illinois Perinatal Quality Collaborative. We are very lucky to have her today to present, given her wonderful depth and breadth of knowledge on this topic. However, before we dive in and have Dr. Borders talk about the work that she's doing and how we can collectively address birth equity, I want to go through a few logistics. As you all are well aware, we use GoToWebinar here at IAMHP for our webinars. You can use the questions or chat function. Should you have a question for me, I'm showing up as the IAMHP admin or IAMHP organizer, depending on the version of GoToWebinar that you have. Additionally, you can use audio through your computer or you can use audio through your phone. You could, should you choose to, alternate between phone audio and computer audio throughout the webinar, though it's worth noting that it may take a slight bit of time to transition. Finally, we regularly are asked if our webinars will be recorded and posted or if our attendees can receive the slides afterwards. If you've registered for this webinar, the slides and the recording will go out at a later date and you will receive them. It will also be posted on our website. Again, I want to thank you for joining us today, and I want to thank Dr. Borders for sharing her knowledge and her time with all of us. And with that, Dr. Borders, I'll hand it off to you.
Well, welcome everyone. I'm so glad to be here with you and to share the work of the Illinois Perinatal Quality Collaborative that we've been doing here in Illinois to really think about the challenges that we see in maternal health disparities nationally and of course here in Illinois, and what are some steps that we can take to address these issues together. I'm going to walk through a little bit about our Perinatal Quality Collaborative, what a Perinatal Quality Collaborative is, and then I'm going to take you through some of the work that we've done to really address maternal mortality here in Illinois. And then I'm going to wrap up by talking about our Birth Equity Initiative, which has started this summer. So if you please feel free to put questions in the chat and let me know what you're thinking about. With that, I'll go ahead and get started. Let me see if I know how to. There we go. So just go through some brief data and definitions, overview of PQCs. Like I said, we'll talk a little bit about our approach. And then I'm going to focus on 3 of our initiatives that we've done, and then the Birth Equity Initiative that we're just getting started here in Illinois with birthing hospitals across Illinois. So this is a pretty striking slide, and so I like to start with this because I think it gets people's attention. We are having a maternal mortality crisis in our country, and if this isn't something that you think about every day like I do and like my team does, I think it's very sobering to look at where other developed countries have moved in terms of their maternal mortality across time compared to where the US has moved. And our healthcare system and our safety nets and our social systems here in Illinois or in the US are certainly failing our mothers in ways that's not happening in other countries. And so the amount of infrastructure and money and thought that's going into having healthy moms and newborns in other countries, we're behind. And so there's a lot of interest in this topic. You're going to see it on the radio and on the news, and legislators are thinking about it. And it's important that all of us think about what we can do in our corner of the world to address this topic. Of course, it's not just that maternal mortality has risen in the US compared to the developing world. We have drastic disparities in our maternal mortality. So if you look at the purple lines on the left, those are Black, the red is American Indian, Alaskan Native, and the blue is Hispanic, the yellow is white, and the gray is Asian, and then the green is total. So you see this kind of drastic disparities for Black and American Indian, Alaskan Native patients in terms of maternal mortality. And this is something that we all have to better understand, and not just understand, but address. This is, the time for action is now. So when thinking about definitions, I think understanding what the difference is between disparities and equity, and you guys have, if you've been to some of these talks, you've probably heard these differences, but disparities are differences in health and healthcare between groups that are closely linked with socioeconomic or environmental disadvantage. And birth equity is the assurance of conditions of optimal births for all people with a willingness to address racial and social inequalities in a sustained effort. And so this is what we're all about. It's that sustained effort. There's nothing that's a quick fix, but we all have to be focused on this issue and moving forward together. Also the difference between equality and equity. So equity is really thinking about what our patients and our populations need to flourish and to have optimal health, and figuring out how we can provide that to them. And that's what equity is all about. So let's talk a little bit about perinatal quality collaboratives. They are networks of perinatal care providers and public health professionals working to improve pregnancy outcomes for moms and women and newborns by advancing evidence-based clinical practices and processes. And there's now a PQC in development or in place in every state in the country. We've been lucky here in Illinois to be funded by the CDC. Also our Department of Public Health and DHS are also important funders, as also some foundations have helped our Prenatal Quality Collaborative here in Illinois flourish. One thing that's really important when we're thinking about maternal health and how we address maternal mortality and morbidity at the population level, there are three kind of key levers we think about, and of course there's others because there's many stakeholders who work on this issue, including our health systems. But when we think about maternal mortality review committees, their goal is to understand how and why women are dying and think about preventable, what we can do to prevent maternal mortality. Our perinatal quality collaboratives are on the ground implementing evidence-based practices. And then the Alliance for Innovation Maternal Health, or AIM, is creating safety bundles and resources that perinatal quality collaboratives and hospital systems can use to implement to really drive evidence-based practices. So CDC, HRSA, and CDC. So our maternal morbidity and mortality committee here in Illinois is very important. ILPQC works closely with MMRC to help think about actionable change through MMRC recommendations. We can move recommendations forward at the state level. And also we've created initiatives in response to our state maternal mortality reviews and reports. So our maternal hypertension, our mothers and newborns affected by opioids, improving postpartum access to care, and our birth equity work all stem from those MMRC work. Let me talk just briefly about our approach as a perinatal quality collaborative. It really does take a village. Here's a picture from one of our recent annual meetings right before COVID. And these are all folks who are there volunteering or speaking at this event. And so lots and lots of folks from across the state, many different stakeholders work together to make ILPQC happen. It really is all about statewide participation. We have a collaborative of physicians, nurses, hospital teams, patients, public health, and other stakeholders who work together to do this work. We implement data-driven, evidence-based practices to improve maternal infant outcomes. We've had over time 119 Illinois hospitals participate in one or more initiative, covering 99% of Illinois births and NICU beds. We also have a robust OB and neonatal advisory work groups that participate, that meet monthly to really advise the collaborative. And we also have stakeholder and leadership groups that advise the collaborative and patients on those various groups. So really working with the community, working with patients, and working with physicians and nurses who are on the front lines of this work to figure out how to move evidence-based practices into implementation and then be able to sustain those efforts. This is what our infrastructure looks like. The hospital teams are really the cornerstone of what makes up the collaborative. They are the collaborative. ILPQC Central is our small group of folks who help organize and support the collaborative. Our advisory work groups I already told you about. And then of course we have leadership committees and stakeholder groups who we meet with regularly to advise our work. It's really important to us to engage diverse stakeholders and expand our network into the community. So we do a lot of work making sure that we are expanding. And so that's a really important part of this. I think it's really important to understand how perinatal quality collaboratives might work differently than say like a public health messaging that comes out or other projects that folks work on. And so really thinking about how to use quality improvement. We have three kind of pillars of our work: collaborative learning. So we get hospital teams to work together and learn from each other. They share their progress, they share their challenges, they share their resources, and they learn from each other, which really motivates quick implementation of evidence-based practices than if we were just asking hospitals to do this on their own. We use data to really drive quality improvements. So our hospital teams collect monthly data. When they collect that data and enter it into the REDCap data system, they immediately are able to see how they have improved across time and how they compare to the rest of the hospitals in the state. And they're getting that input every month. So that really helps drive looking at the process measures, outcome measures, and structure measures monthly, really important for the quality improvement work. And we do a lot of quality improvement support. We have a theme that's leave no hospital behind. So some hospitals have lots of quality improvement support at their fingertips and some don't. And we are here to help everybody. We work on PDSA cycles, 30, 60, 90-day plans, and other QI efforts to get this work done. This is just a list of our initiatives over time, starting back in 2014 when the collaborative was founded and we started on early elective delivery, birth certificate accuracy, maternal hypertension. You can see in peach is the neonatal initiatives. We then did the Hypertension Initiative. IPAC was improving postpartum access to care. We did an immediate postpartum LARC, helping hospitals to implement immediate postpartum LARC, access to IUDs and implants for patients to have access to effective contraception before they left the hospital, something that had been really hard for hospitals to do on their own, this implementation once the Medicaid plans reimbursed for immediate postpartum LARC. And then we worked on our mothers and newborns affected by opioids, or M&O initiative, for the last 3 years to improve optimal care for our patients affected by opioids. And I'll be talking a little bit about that initiative. And then here in 2021, we've launched our Promoting Vaginal Birth, reducing NTSV C-sections, on our birth equity work on the OB side. On the neonatal side, they've done work on nutrition, golden hour resuscitation efforts, also the mothers and newborns affected by opioids, but on the neonatal side. And the basic initiative is antibiotic stewardship. So I think it's really important that when we are thinking about why we do this work, we keep in mind our patients' faces and women's faces. These are all women who've died in childbirth or soon after. And this is really why we do this work. It's really about patients and patient stories, and we try to keep that at the center of the work that we do. So I'm going to take a minute now to go back through some of our initiatives and give you some highlights so you can see some of the work that hospital teams, physicians and nurses and patients have been working on across the state through the collaborative. So I'm going to start with the Hypertension Initiative. We did this work between 2016 and 2017 with 110 hospital teams, and then moved into sustainability with 86 teams. And our goal was to reduce severe maternal morbidity in women with severe maternal hypertension, increase treatment of severe hypertension to under 60 minutes, which was standard of care, improve patient education on preeclampsia, improve patient follow-up in the postpartum period, and improve provider and nurse debriefs, and really talking about whether they had achieved time to treatment. So we're really proud of this data. If you look where the blue line is, only 41% of patients were treated in standard of care, which is to treat severe hypertension in under 60 minutes when we started this initiative. By the end of the initiative, we were between 85 to 90% of patients were treated within 60 minutes. And the dark green are patients treated within 30 minutes. So really, we're able to achieve significant improvements in care for women with hypertension and pregnancy in the postpartum period. Another thing we found is that we found no significant differences in the proportion of hospitals achieving the goals based on their demographics, their race ethnicity mix of their hospital, their Medicaid mix. So we were able to really help all hospitals across the state to make these improvements regardless of their patient population, their demographics, or the geographic. This is patient education. Again, you see only about 30% of patients were getting postpartum education on hypertension and preeclampsia when we started, and we were up, around 90% by the time we stopped the initiative. And this is getting patients back for a early postpartum follow-up to check their blood pressure. And again, we saw significant improvements. Most importantly, we were able to reduce severe maternal morbidity significantly by about 50% across the initiative for women with severe maternal hypertension. So really improving optimal care for women with hypertension matters, and it significantly improved outcomes for our patients. Now I'm going to spend a little bit of time talking about our opioid initiative. So I think it's really important. Most people have heard by this time that there's an opioid crisis going on in our country. And I think what's important to understand is that this did not leave mothers and pregnant and postpartum patients behind. Opiate overdose has become one of the leading causes of maternal death in Illinois. The most recent maternal morbidity report that came out in April reported mental health disorders, including substance use or overdose, as a leading cause of maternal death. When you look at pregnancy-related deaths, and if you look at pregnancy-associated deaths, the biggest proportion of those were overdose deaths related to opioids. When you look at the significant increase in pregnancy-associated deaths due to opioids, you've seen that opioid overdose has just skyrocketed in terms of killing our pregnant and postpartum patients in Illinois. And if you look at the number of deaths related to opioids, like in 2017, we saw 20 maternal deaths related to opioids, 6 related to hemorrhage, and 6 related to hypertension. So really, the maternal deaths related to opioids are just really dwarfing and a significant problem that we needed to address. Now, I think that if you look at the disparities, we do see that there are more maternal deaths among Caucasian patients, rural patients, when you break this down, and more deaths from chronic conditions when you look at deaths for our Black patients and patients of color. But when you look at overall deaths, opioids is an issue that we could not leave behind. The other thing that has been really troubling is that the COVID pandemic has worsened the opioid crisis. We've seen opioid overdoses skyrocket, and we've seen headings and newspaper headlines all summer and over the last year talking about the increasing number of overdose deaths. And we've seen worsening disparities in overdose deaths with increasing overdose deaths in our Black patients and our patients of color. So we developed the Mothers and Newborns Affected by Opioids Initiative based on what we were seeing in the Maternal Morbidity Review Committee. We developed this to be able to improve screening, so universal validated OUD screening. So that's asking patients with self-report. And we're not talking about urine screening here. We're talking about using universal validated screening with a self-report to screen women for substance use disorder in the prenatal settings and during labor and delivery. So talking about substance use disorder during pregnancy and during the delivery admission with all patients. For patients who screen positive for opioid use disorder, linking them to medication-assisted treatment, linking them to recovery treatment services, completing an OUD clinical care checklist, including providing Narcan counseling and a prescription and a hepatitis C screen, and then counseling moms and really empowering them on the importance of the engaging pregnant and postpartum birthing patients in participating in newborn care, non-pharmacologic care, breastfeeding, skin to skin, and rooming in. All those are really important and something that hadn't been done commonly. So all of these together make really optimal care for patients with opioid use disorder. One thing we found is that we really had to change the culture on labor and delivery and among obstetric clinical teams who saw opioid use disorder as more of a social issue than a clinical issue. And we really had to move to this point of helping to educate folks that opioid use disorder is a life-threatening chronic disease with a life-saving treatment available, and that it was an urgent obstetric issue, and that there was key steps that OB providers needed to take prenatally and on labor and delivery to care for women with opioid use disorder and provide optimal care. So this idea of optimal OUD care from obstetric teams became really important. And I think that this kind of old way of thinking was that if you had a patient with opioid use disorder, you needed to call social work so they could talk about TCFS, and you needed to let the neonatologist know because they needed to talk about neonatal abstinence syndrome. And we really had to get away from that old way of thinking, which was so stigmatizing, and really think about the patient in front of you, the patient with opioid use disorder, as having a life-threatening condition and being a very high-risk patient who needed your attention and needed your care and needed your follow-up and needs to receive optimal OUD care in order to reduce the risk of overdose deaths, improve pregnancy pregnancy outcomes, and increase the number of women who can parent their baby. And we said those three things over and over and over again, that when you link moms to medication treatment, buprenorphine, methadone, and you link them to recovery treatment services, you reduce overdose deaths, you improve pregnancy outcomes, and you increase the number of women who can parent their baby. We talked so much during this initiative about optimal care for all pregnant, postpartum persons with OUD. This became really, really important to get this message across. So again, screen every pregnant patient for OUD with a validated screening tool, assess readiness for medication-assisted treatment, link to MAT and recovery treatment services, provide naloxone and Narcan counseling and prescription, and screen for hepatitis C, warm handoffs for MAT and recovery treatment services, and close obstetric follow-up, provide patients education on OUD and neonatal abstinence syndrome, and reduce stigma and promote empathy across your clinical team. So those 6 items became really important in this initiative. We have to talk about optimal OUD care. We have to measure optimal OUD care, and we have to implement optimal OUD care if we're going to save lives and get these moms into treatment and reduce the risk of maternal death. So these are some of the tools and resources we use for our teams. Universal screening for substance use disorder and opiate use disorder with a validated screening tool. These are recommended for all pregnant patients by ACOG, SMFM, and ASAM. We're to screen all pregnant women upon entry to prenatal care and again on admission to labor and delivery, and then document the screening results. This allows for the earliest possible intervention and referral to treatment. The goal of screening is to identify women with life-threatening illness to start treatment early in pregnancy or before delivery discharge. These are some of the screening tools that we recommended that were used across the state. The 5 Ps, the integrated health screen that has the 5 Ps in it, the NIDA quick screen. These are all screening tools that hospitals across Illinois implemented and have implemented. We also found that when you're implementing screening, one thing you want to do is provide resources so that if someone screens, they know what to do if someone screens positive. I think providers and clinical teams were very worried that they were going to screen someone positive and they wouldn't know what to do to provide optimal OUD care. So we created M&O folders that went out onto every labor and delivery across the state. They went to prenatal offices so that when someone implemented a screening tool, screened someone for substance use disorder, and they screened positive for OUD, they would pull an OUD folder, the M&O folder. On the left-hand side were these wonderful patient education materials that we developed with patients for prescription pain medicines and pregnant women, NAS, you are the treatment, NAS, what you need to know, and then contraception counseling. So really great resources for patients were very empowering. And on the right side was clinical team resources. So the clinical treatment algorithm on how to provide optimal care, the OUD clinical care checklist that should be filled out for every patient with opioid use disorder during pregnancy and a postpartum. And then the Narcan resources were really important because we found many OB providers did not know how to counsel or prescribe Narcan. Not something they learned in medical school, not something they learned in residency, but now incredibly important that all patients who use opioids regularly or who have an opiate use disorder absolutely need Narcan counseling and prescription. So we gave them a quick start guide to hand to the patient to talk about how you use Narcan, and then Save a Life counseling and prescribing guide. So this has a little QR code that really pulls up a Narcan prescription. It has an example Narcan prescription and has steps of what to say to the patient. So everything you need to be able to prescribe Narcan, even if you've never prescribed it before. The OUD protocol, and then also a nursing workflow is in the folder. So patient education on OUD and NAS, these are those resources I was talking about. We developed these with patients who had opioid use disorder, who'd had babies in the NICU with NAS, and they're really well developed to empower moms, pregnant and postpartum birthing patients, to be able to engage with their newborns. And so these are really helpful, and these materials were all in the M&O folders. The other thing we did was provide resources for education for all OBs and RNs. And again, a lot of people were not trained on how to provide optimal OUD care. A lot of our nurses and our physicians really didn't know much about it, or how to talk to patients, or what optimal OUD care looks like, and certainly didn't know that it was one of the leading causes of maternal death in Illinois. So we developed some stigma and bias education, a wonderful Words Matter e-module. And it's a video of a patient talking about her experiences during pregnancy and in the NICU with her newborn, which hospital teams across Illinois have used. We also have a CDC opioid use and pregnancy e-module that has stigma and bias education in it. We also created 2 e-modules, one for OB providers and one for nurses that goes through optimal OUD care. We created an education campaign with flyers and posters that were posted, and magnets that were posted across birthing hospitals in Illinois, talking about how to prescribe Narcan, what optimal OUD care looks like, and then some of the resources from DHS, others, the opioid helpline, where folks could call 24 hours a day, 7 days a week, and figure out where the nearest medication-assisted treatment or recovery treatment services are available. So that's an incredibly helpful resource. We also provided a simulation guide to help folks do simulations, any module trainings, and then a short expert training that was 6 minutes. So lots of great resources. Let me briefly go through the data before I wrap up this work about opioids. So we had 92 teams who participated and submitted data, over 2,500 pregnant and postpartum patients with opioid use disorder, about 71 per month were entered into the data system. And we also screened women. We also did a data pull where every hospital pulled 10 charts per month and looked to see whether women were screened for substance use disorder prenatally and whether they were screened on arrival to labor and delivery. So this is structure measure changes. Teams put in red if they hadn't started working on the structure change yet. They moved to yellow when they were working on it, and they moved to green when it was implemented. So this was just a lot of work putting systems changes in place in Illinois hospitals, and you can see that the teams just did an amazing job of implementing these systems changes. So getting validated screenings in place, having mapping tools in place, getting expert protocols and algorithms in place, having standardized patient education, and then implementing a clinical care checklist on labor and delivery. So lots of work to provide optimal care to these patients. The left-hand upper corner is our prenatal screening rates for the delivery admission. And what you can see is pretty miraculous quality improvement work. When we started, almost 0% of patients in Illinois, when they came onto labor and deliveries, were screened with a validated screening tool for substance use disorder. And when using this random sample, now over 22,000 patients in the data set, where over 85% of patients are now screened with a validated screening tool for substance use disorder on arrival to labor and delivery. And again, this is a self-report screening tool. Prenatally, it's been harder work. We have been making slow and steady progress, but we're still about 45%, somewhere between 45 to 50% of patients are screened prenatally. Of course, this is the most important time for screening. So there's a lot of public health work yet to be done to figure out how to get patients screened prenatally with a universal validated self-report screen for substance use disorder, given it is one of the leading causes of maternal death. This is getting patients linked to MAT in the blue line and getting linked to recovery treatment services. So again, we made significant improvements in getting our patients linked to MAT and to recovery treatment services, either prenatally or during that delivery admission before delivery discharge. We made significant improvements in Narcan, but there's much work to do still on the public health front to get OB providers to know that every single patient that they encounter with opioid use disorder needs Narcan counseling and a prescription. That's such an important risk reduction strategy to save lives. And right now, we're really still around that 50% mark of patients getting even Narcan counseling, let alone that prescription. So we've certainly made improvements, but there's much work to be done to make sure that women, that pregnant and postpartum birthing patients are receiving Narcan counseling and a prescription prenatally, ideally, and certainly before they're discharged home. In a perfect world, any patient admitted with an opioid use disorder diagnosis would not be discharged postpartum without Narcan naloxone counseling and a Narcan naloxone in their hand. We would love more point of care availability of Narcan like they're doing in emergency rooms. We'd like that to happen on labor and deliveries as well. We've also focused on equitable care here in our M&O initiative. When we started this initiative, you saw a big difference between our Black and white patients in terms of linkage to MAT. About 45% of white patients were linked to MAT when we started this initiative, and only about 24% of our Black patients were linked to MAT. You can see just a steady narrowing of that gap, that disparities gap across this initiative as we work to make sure every patient receives appropriate optimal OUD care. And you can see by the end of 2020, we had closed that gap. Also, if you look at the work we've done on breastfeeding and improving non-pharmacologic care of the opioid-exposed newborn, you can see a big disparity in breastfeeding for our Black patients in blue and the white patients in orange. And again, that gap was closed across the initiative. So briefly, before I turn to the equity and birth equity initiative that we're currently working on, I'd like to just share another initiative we did. It was a smaller initiative with 16 hospitals over the last 2 years. And this initiative was all about improving postpartum safety. So it's IPAC, improving postpartum access to care. This again comes out of our Maternal Mortality Review Committee results that show that the postpartum period is really quite a dangerous period for women in terms of maternal deaths. And that 0 to 42 days, even before women come back for that 6-week postpartum visit, is a really important time period for women to develop complications. So our goal was to implement a universal 2-week postpartum maternal health safety check. So every woman coming in for a maternal health safety check at 2 weeks postpartum and having that scheduled before delivery discharge. We also provided postpartum safety education before delivery discharge for all patients on 3 key areas. Post-birth warning signs, so what are the warning signs they should know, and put that on your refrigerator. And then what are the benefits of early postpartum follow-up, really empowering women. Why are you coming back for a maternal health safety check at 2 weeks? What's going to happen there, and why is it important for all women? And then we also provided information on healthy pregnancy spacing. Again, really important in terms of safety for moms and improving pregnancy outcomes to have healthy pregnancy spacing. So really thinking about what the benefits are for that healthy pregnancy spacing. These are the 16 hospitals that participated. We saw incredible response to this initiative. Providers, nurses, and patients really liked the maternal health safety check at 2 weeks. They had incredible reports of high satisfaction with both scheduling and then having these appointments. So we started out only 2% of patients were scheduled for an early postpartum visit at delivery discharge, and we were over 90% by the end of the initiative across those 16 hospitals. Again, the postpartum safety education, very few patients were receiving postpartum safety education before we started this initiative. We were over 90% by the end of the initiative. I'm going to briefly talk about our Promoting Vaginal Birth initiative, which we're working on now in Illinois, and this is really to promote vaginal births and reduce C-sections. You can see these are every birthing hospital in Illinois. You can see a huge variability in C-section rates across Illinois. So our goal is to support vaginal births and reduce primary cesareans for optimal maternal and neonatal health. Our goal is to have 70% of participating hospitals at or below the Healthy People goal of 24.7% cesarean delivery among NTSB births by December 31st, 2022. Our other goal is to increase the percent of cesarean section deliveries among NTSB births that meet ACOG SMFM criteria guidelines recommendations for cesarean, and then increase the percent of physicians, midwives, and nurses who've been educated on ACOG SMFM criteria, labor management strategies, response to labor challenges, protocols for facilitating decision huddles, decision debriefs, and patient-centered decision-making. These are the kind of 3 buckets that we're working on with this initiative: optimizing labor management and support, protocol guidelines for induction and labor decision-making, and the provider and nurse and patient education to support clinical culture change. These are kind of the key strategies our teams are working on. So identifying NTSB deliveries so that everyone on labor and delivery is aware, and when a patient who's going through their first term spontaneous vaginal delivery, education about ACOG SMFM guidelines and recommendations for providers and nurses around cesarean decision-making, implementing a cesarean decision checklist and huddles with patient-centered decision-making, labor management support classes for providers and nurses, and then developing standardized processes and protocols for induction, early labor, and labor challenges. So here's our toolkit, which is available at www.ilpqc.org, has lots of really great resources regarding the PVB initiative. And then here is some data. Our baseline NTSB C-section rate by hospital, we had 39 teams above the goal. That's already improved. Here's some of our structure measures that we're working on with our PVB teams. It's really integrating processes to review and share data that includes provider level data, implementing provider and nurse education, other strategies to achieve buy-in, implementing standardized protocols and processes for induction, labor management, and response, and then implementing a cesarean decision checklist. So you can see teams already are working on this. Again, red means they haven't started working on it, yellow working on it, and green you have it in place. This is our data that we have so far through May, looking at whether hospitals are meeting the ACOG SMFM criteria for the cesarean deliveries. So cesarean after induction, we've increased, now we're up to about 60% of deliveries meeting the ACOG SMFM guidelines, but our goal is 80%. Labor dystocia, we're at about 50%. Fetal heart rate concerns were above goal, and then total NTSV sections, if you look overall, we're approaching 70%. So our goal is to get above 80% of deliveries achieving ACOG SMFM guidelines. With that, I'm going to spend the remainder of the time talking about our birth equity initiative. We just launched this initiative with our first big kickoff just a few weeks ago. So we've already talked about the disparities that our country is facing, but I think it's really important to circle back to this, because I don't think we can emphasize enough why this is so important that everyone work on this issue, why every birthing hospital is being called to this work, why all kind of sectors who work on public health are really focusing on maternal mortality and these disparities. So about 700 women die from results of pregnancy or postpartum complications. American Indian, Alaskan Natives, and Black women are 2 to 3 times more likely to die from pregnancy-related causes than other race and ethnicity groups. And here you can see this data from the CDC. If you look at our data here in Illinois, this is severe maternal morbidity. And what you can see again is that Black women are about 3 times as likely to die as white women in Illinois. 83% of pregnancy-related deaths are potentially preventable based on MMRC review. Compared to non-Hispanic white women, all other racial and ethnic groups have a higher rate of severe complications during pregnancy and the year postpartum. So lots of important work to be done. So why are there disparities in maternal health? How can we address these disparities? So really thinking about variation in quality and access to healthcare, structural racism that impacts patients in their communities, where they live, where they work, where they play, where they grow. And those really impact our social determinants of health, access to healthy foods, access to transportation, access to housing, safety, education, work, all those determinants that really do impact our patients' health. Underlying chronic conditions often related to those social determinants of health, and then implicit bias in our healthcare system and in other services that impact our patients. So how do we address disparities? So inequity, structural racism, and bias in case of care are associated with disparities in outcomes. What can we do? So really focusing on identifying inequities in care, understanding bias in care, and promoting equity. So the Birth Equity Initiative is a foundational initiative for all Illinois birthing hospitals that will build on existing hospital efforts and lay the groundwork for ongoing equity work in a statewide quality improvement initiative to address maternal disparities and promote birth equity. And we really do mean, when we say it's for all birthing hospitals, this work is important regardless of hospitals' demographics. We have many hospitals across the state who may not have a diverse patient population. And yet when we think about the issues we're going to be addressing here, social determinants of health, bias, postpartum safety, these are issues that are important for all patients. And certainly regardless of where your hospital is or your patient mix, there are patients who may be experiencing bias or not be receiving respectful care at your institution. And so this really is important work for all of our hospitals, regardless of their patient mix. And so we're really encouraged by the response across the state. There is support for this initiative statewide. So the state legislation, Public Act 101-0390, stated that we would, ILPQC would run a birth equity initiative with support from IDPH for Illinois birthing hospitals. IDPH sent out a letter of support to all Illinois birthing hospitals, encouraging them to participate in this initiative. And then the IDPH Maternal Morbidity and Mortality Report that was just released in April also stated a recommendation that hospitals participate in this initiative. We are really working hard with other states to do this work. We meet regularly with California, Massachusetts, and New York, all states who are working on birth equity initiatives in their states. We talk monthly to them to share ideas and learn from each other. And then, of course, we work really closely with ACOG, SMFM, AIM safety bundles to really make sure that the work we're doing here in Illinois reflects best practices of folks who are thinking about this across the country, but then also is uniquely responsive to our needs here in Illinois, because we're not just learning from others outside of the state, but really talking to stakeholders, patients, and community groups here in Illinois to make sure that the work that we're doing is really reflective of what our patients and our communities need. So what are we focusing on? So we're working to address maternal disparities and promote birth equity. It started in June 2021 with our first kickoff. We've had 86 teams, hospital teams across Illinois participating at this point in the initiative, which is really exciting. So 86 out of about 100 birthing hospitals in Illinois. Our goal by December 2023 is to have 75% of Illinois birthing hospitals participating, and 75% of participating hospitals have all key strategies in place. So really exciting. The big kind of buckets that we'll be working on: addressing social determinants of health, reviewing race, ethnicity, medical record, and quality data, promoting patient-centered approaches to engage patients and communities, and then developing respectful care and bias education for providers, nurses, and staff. So again, these are those 4 key drivers that you'll see again and again when talking about the Birth Equity Initiative: addressing social determinants of health, utilizing race, ethnicity, medical record, and quality data, engaging patient support partners, including doulas and communities, and engaging and educating providers, nurses, and staff. So I'm just going to break this down briefly to go through those 4 areas. So when we're talking about addressing social determinants of health, we're going to be helping our hospital teams to map social determinants of health community resources and services available to patients. We've put together folders and packets that are available on our tool in our toolkit, the Birth Equity Toolkit on the ILPQC website, if you want to take a look at it. These have really great resources for social determinants of health. We also have some resources for patients that hospitals can use, NowPow and other online resources that are going to be available through ILPQC to help hospitals electronically link their patients to resources and services. We're going to be working with our teams to screen all patients for social determinants of health, so doing a universal social determinants of health screen during prenatal care and again at delivery admission, and then linking patients who screen positive to resources and services, and incorporating social determinants of health and discrimination factors in hospital maternal morbidity reviews. The next area that our teams are going to be working on is really optimizing how we use race and ethnicity data that comes from medical records and quality. So accurately collecting patient-reported race and ethnicity data. This is all about optimizing the collection of patient-reported race and ethnicity data. We've been doing focus groups with patients. How do you ask these questions? How do you approach patients to do this in a way that we know we're getting self-reported data from our patients so that we can use that data then to look at our quality efforts. Implementing a maternal health report or dashboard with data stratified by race, ethnicity, and health insurance status. So you really can review our local disparities and identify opportunities for improvement. So really understanding our maternal health data at the local hospital level by race, ethnicity, and by Medicaid status. And then reviewing, reporting and reviewing patient-reported experience data. Engaging patients, support partners, and communities, so identifying a patient advisor for quality improvement teams. And we're really interested in looking at different opportunities for teams to work with patients and community members in this quality improvement work. And we've been engaged with EverThrive to help us do the best job possible to make sure our teams have access to and coaching on how to engage patients and communities. Implementing a strategy for showing respectful care practices with patients, families, labor support, and delivery staff. So we'll be working on respectful care practices with our hospital teams, and then sharing those respectful care practices with patients, and then doing a patient-reported experience measure with all patients before they leave the hospital, before delivery discharge, where they can report back on those respectful care practices, and that data then will get reported back to teams. So that really we close that loop of not just talking about respectful care practices, but really understanding how our patients are experiencing those respectful care practices and then getting our feedback back to teams. That's really a focus on clinical culture change and making sure that we're really keeping respectful care and patient-centered care at the center of all the work that we're doing on labor and delivery. The other thing we're working on is postpartum safety, so providing patient education on urgent maternal warning signs, early postpartum follow-up, and other elements of postpartum safety. Finally, engaging and educating providers, nurses, and staff. So educating providers on the importance of listening to patients, providing respectful care, and addressing implicit bias, and then implementing strategies for addressing diversity in healthcare team hiring. So all of this information is in our toolkit. That's a lot to cover, and I think one of the things we're focused on with our hospital teams is that this is taking steps on this journey, and we have time to do this work together. No one is expected to do all this work at one time. Many of our hospitals are dealing with having burnout and exhaustion from teens from dealing with the COVID pandemic. And so we're taking this work on with a spirit of collaboration and a spirit of knowing this is incredibly important work, knowing that hospitals are doing some of this work already at a kind of overall hospital level. And we're providing resources and services to make it easier for teams to do this work at their local labors and deliveries. So kind of the 6 key things, if we could summarize all the stuff I've talked about, is implementation of universal social determinants of health screening, prenatal and during delivery admission with linkage to appropriate resources and services, reviewing maternal health quality data stratified by race, ethnicity, and Medicaid status to identify disparities and address opportunities for improvement. Those are the first 2 areas that a lot of our teams are starting to work on. Number 3 is taking steps to engage patients and our community members to provide input on quality improvement efforts. So figuring out opportunities, that may be focus groups, that may be a meeting where we bring in community members and patients and talk about our birth equity initiative at the local hospital level. So different ways we can engage patients and community members. Number 4 is implementing a strategy for sharing expected respectful care practices during delivery admission with patients, labor support persons, and obstetric staff, and survey patients before discharge on their care experience using the PREM tool that we're going to be providing to our hospital teams to provide feedback. Number 5 is standardizing systems to provide patient education prior to hospital discharge on postpartum safety, including urgent maternal warning signs, tools to improve communication with providers and early postpartum follow-up. And the last is implementing education for providers and staff on the importance of listening to patients, providing respectful care, and addressing implicit bias, and provide opportunities for discussion and feedback. So this is our birth equity toolkit. It's available online at this link here. Lots of resources to do the work that I've just described to you all. And that is the end of my presentation, but I'm certainly open for questions and comments that folks have about the work that ILPQC is doing across Illinois to promote birth equity and improve outcomes for moms and newborns.
Thank you so much, Dr. Porters. This was absolutely an amazing presentation, chock full of critical information. I want to remind everybody that yes, you will be getting the PowerPoint, and so like for the links that Dr. Porters referenced, we will be sending that out. You'll have that information. You'll also receive a recording of the webinar, and it'll be posted on our website. So if you want to go back or you want to share this with the team member who's not on, you'll be able to do so. So we always get that question, and we will send it out to all registrants in short order. One question, Dr. Porters, that came up from the plans, the Medicaid health plans, is how they can assist ILPQC in engaging hospitals, making sure hospitals know about the work that you're doing. You know, obviously they're also regularly interacting with these hospitals. If there's information they could share with their provider networks, either their OBs or their hospitals, how can they be a partner in this work?
We would love that so much. You know, I think that the stakeholders who work with us on this work, whether it's the Hospital Association or ACOG or others, you've really named some of the ways I think that are really important. So communication is really important. We know that it takes a lot of different levers to get success. So if everybody is kind of communicating the same thing to providers and to hospitals, it's harder to not hear the messages, right? And so we would love, we definitely have snippets of information like one-pagers or information that's directed towards OB providers and nurses or stuff that could be more directed to hospitals. And so we would love to work with you to think about how can we communicate out messages about sustainability with the opioid, how do you provide optimal OUD care, or improving postpartum safety, or particularly this birth equity work that is so vitally important. So certainly communication with providers and hospitals is incredibly important. And then I think really thinking about where some of the sticking points are. So if you look back on the opioid work that we've done, how can we use levers to improve screening, universal screening for substance use disorder during prenatal care and during that delivery admission, right? Particularly prenatal care has been hard. And so are there ways or levers that we can think about that, whether it's a quality measure or some other measure that says, we need to make sure that all women are screened for substance use disorder with a validated self-reported screening tool. That is standard of care, and we know it's happening in only about 50% of patients right now across Illinois prenatally, much better during the delivery admission. We know that women who have an opioid use disorder diagnosis need to be linked to medication-assisted treatment, linked to recovery treatment services during pregnancy or during that before delivery discharge. And then we know that patients need Narcan counseling and a Narcan prescription. And that's something that's been really challenging to do. So those kinds of messages or other levers that you can bring there, whether it's quality metrics, to say, you know, we really need to make sure this is happening because this is one of the leading causes of maternal death, kind of regardless where you are in the state. You know, we see overdoses in every county in Illinois. So that's important messaging. And then when we think about the birth equity work, you know, there's going to be a lot of interest. How do we increase universal social determinants of health screening and effectively linking to resources and services? So whether it's using NowPow or another online linkage to resources and services, we know that social determinants of health are directly related to our disparities we're seeing. And so how do we do a better job of thinking about this as this is important to bring into our clinical context? We must be thinking about social determinants of health when we bring women in for prenatal care. We spend a lot of time and energy checking women's blood pressure and measuring their urine for protein. But are we finding out if they have food at home or if they have a reliable place to stay? Those issues may more directly impact pregnancy outcomes than some of the things we've historically done. And I'm not saying that the prenatal care we do is not vitally important, but these other issues must be thought of in a clinical context. And so changing that culture, though, is hard. And we have OB providers and prenatal spaces that are overburdened, understaffed. And so figuring out how to help providers and staff think, how do we screen for a substance use disorder? How do we screen for social determinants of health? Some of these things that really matter. You know, if we think about this kind of universal screening, substance use disorder, social determinants of health, domestic violence, and mental health issues, those cover a lot of the areas that we see women directly related to maternal mortality, but we haven't spent as much time on those kind of universal screening prenatally and postpartum. We have paid attention to the mental health screening because it was made a state law. And so screening for perinatal depression is something that's now really ingrained culturally in the clinical context prenatally and during the postpartum period, but not so much those other really vitally important screening tools. So how do we think about potential quality metrics that could help our providers and our hospital teams do this work? And again, it's just different levers coming from different places, but I do believe there's a lot of opportunities. The same with the improving postpartum safety, maternal health safety check at 2 weeks for all patients. How do we make sure that's happening? How do we make sure that's getting reimbursed appropriately so that we don't have this idea from providers that, oh, we can only have one postpartum visit because that's all that's covered, when really standard of care says that patients should be seen at 2 weeks and at 6 to 8 weeks. And so a maternal health safety check should be there for all patients as a preventative health visit, not just for patients who are sick. So those are some of the areas that I think there's a lot of overlap and a lot of opportunity for collaboration.
I could not agree more, Dr. Borders. There's so much overlap here. The Medicaid health plans are really the payers for, you know, probably, you know, 40 to 45% of all births.
Of course.
And when you think that Medicaid's covering 50% and the majority of these moms are going to be in Medicaid managed care. So there's a real opportunity there. So I'm definitely thinking we're going to discuss some of these items that are upcoming CMO committee and talk about how we can collaborate with ILPQC and the work, because there is so much overlap.
Absolutely.
We will share the toolkit that is in your PowerPoint. I did want to ask, are the validated screening tools that you've referenced, are they within that toolkit, or is there another place where, oh, perfect.
Yeah, all of those screening tools are available. And if you have any trouble, you know, if you basically go to our website, you'll see the different initiatives. So you'll see the MNO, the Mothers and Newborns Affected by Opioids, the OB toolkit, and a neonatal toolkit. You'll see the IPAC, Improving Postpartum Access to Care toolkit, and you'll see the Promoting Vaginal Birth, the Hypertension, and the Birth Equity toolkit, which was just released.
Perfect. Perfect. Now, one thing that that was discussed and that we are also working on this, the Medicaid health plans, and that is the collection of demographic data and the challenge that can present. And so we've actually worked with NCQA and others and sort of understanding best practices around that. NCQA has a certification for health plans, you know, on cultural humility, and so we understood, you know, looked into that. And one thing that came up through that work and that understanding is that by informing the patient why you're collecting that information, or for us, the member, that you actually see an increase in collection. And so I think
absolutely, that's exactly what our patients, you know, in our focus groups and some of the national resources that we have in the toolkit. We have scripts and things that, and I'd love to make sure that we have the resources you're talking about, Samantha. So if you can email me those to make sure that we have those included. But you're absolutely right. It's about making sure patients understand why they're being asked their race and ethnicity. And I think that was the biggest issue that came up, that in our focus groups, of course, patients are very suspicious. Why do you need my race and ethnicity? Are you going to treat me differently if I give you my race and ethnicity? So I think it just is absolutely aligned with the trust issue, and making sure that we're talking to our patients about why the race and ethnicity data is being collected, doing it in self-report, and then also making sure that patients can verbalize how they see their race and ethnicity. So, you know, someone asked me if I'm African American. I'm Black. You know, so there was just a lot of quotes that came out of that work. I think that was important when we're talking about, you know, giving people the different options of how they view themselves, collecting that data appropriately, and making sure patients understand why the data is being collected. All those things came up in the work that we did, the kind of pre-work, and many groups across the country are really interested in optimizing collection of self-reported race and ethnicity data. So there's just been a lot of really impressive work done on this. So I think we'll be working with our hospital teams to figure out how do we improve scripting around how we ask these questions, the kind of data we're collecting, and really making sure that we're then using the data to address quality.
Perfect. And my last question that I got was how are hospitals selected to be a part of these various initiatives? I think they do self-select, but can you talk just very briefly on that process in our last meeting?
Yeah, so we send out a letter of invitation to all hospital teams when we are going to do an initiative. And so that's how hospitals participate. We ask them to submit a roster by a certain date, and then do a readiness survey. And the roster has, you know, a nurse champion, a physician champion, quality improvement person, a patient, bedside nurses, an outpatient representative, social worker, you know, so there's a lot of different folks who are on that roster. But hospital teams basically get a invitation. A letter comes out from the Department of Public Health and from us, inviting them, and then we talk a lot about these initiatives on the different ILPQC meetings and events that we have. And we also work with the regional perinatal system to make sure that the perinatal networks, the hospitals, all know about the initiatives that are coming up. And then they have to submit a roster by a certain date. However, we do accept rolling. So if there's hospitals, for example, who wanted to join birth equity who didn't start, we would work with them to figure out how to get their baseline data in, get their readiness survey in, and get started with the initiative, even though they didn't participate initially. And sometimes, you know, you'll have a CEO who doesn't realize that their hospital isn't participating, but it's like, oh, we really should do this. Or you have an OB chair who's like, we should absolutely do this. And you want to make sure that everyone knows what everyone else is doing. It's work that's really important. And I think this is work that hospital leaders want hospitals to be doing. And so this is an opportunity for labor and delivery to do some leadership and some work on this topic that's going to be so important, I think, for most hospitals to be addressing.
Perfect. Thank you so much, Dr. Borders. Thank you for your time, for your work, for really making a difference and taking time out of your very busy day to educate all of us on everything that you are working on. I want to thank all of our attendees for taking an hour out of their day to become more informed on the great work of Dr. Borders and her team and the ILPQC. And I want to just remind everybody you will be getting the webinar recording and the PowerPoint and the resources that Dr. Borders shared with us later this week. You should get the PowerPoint slides today and then the recording a little bit later. Thank you again and have a wonderful day.
Bye, everybody.